As promised, we are following up our range of motion lecture with a stretching for impaired mobility lecture. So we are going to bridge over now into stretching as compared to simply range of motion, which we were talking about in the previous lecture. So stretching, big thing here is that we're trying to increase the mobility of soft tissues and thereby improve range of motion. We're going to do that by elongating or lengthening the structures that have become shortened over a period of time. So again, this is trying to gain new range of motion in the attempts to get the person back to normal ranges of motion. Flexibility is looking at the ability to move a joint or a series of joints smoothly and easily through unrestricted range of motion. So this is looking at not only joint integrity, but a lot of the soft tissue length as well. We can look at this as either dynamic flexibility or passive flexibility, which is pretty much what it sounds like. Dynamic flexibility is also going to be referred to as sort of your active mobility or active range of motion, which is the ability of the patient to actively run through a flexibility program, versus passive flexibility or passive range of motion is when some sort of external force is going to passively move that joint through the available range of motion. Typically, we do need to have passive flexibility before we can have dynamic flexibility, right? The motion needs to be there passively, and then the person can work into active flexibility as well. So how we can look at classifications of decreased range of motion. Hypomobility is going to be decreased mobility or restricted motion. A contracture is going to be an actual adaptive shortening of soft tissue around a joint. And we will talk about the different types of contractures. So contractures are first identified by identifying the action of the shortened muscle. So usually by example, it's easier to understand this. So if a patient is unable to fully extend their elbow, then they have shortened elbow flexors, and therefore they have an elbow flexion contracture. Their elbow is stuck in flexion, right? So elbow would be stuck in flexion. It's the biceps, the elbow flexors that are going to be tight. That's what's going to be limiting the ability to pull them into elbow extension. So that would be an elbow flexion contracture. So by the same token, if we have a patient who's unable to dorsiflex, so that means they're stuck in plantar flexion, right? They can't dorsiflex. So which muscles are shortened and how was this contracture be named? So that would be a plantar flexor contracture or plantar flexion contracture or Achilles contracture. It's the Achilles tendon or the plantar flexors that are shortened, that are contracted, that are not allowing the patient to dorsiflex. Okay? So there's four major types of contractures. The first is a myostatic or a myogenic contracture, and this means that it comes from the muscle itself. It's a shortening of the muscle, which can produce a loss of range of motion. There's no significant pathology. This is pretty typical following things like immobilization. The muscle is going to shorten up, or after an injury, surgery. These will typically resolve in a relatively short period of time, a couple weeks maybe, through stretching exercises, active stretching, passive stretching, however we decide to stretch. But these are typically reversible type contractures. Then we get into pseudomyostatic. These are a little bit more challenging to work with. This is a loss of range of motion, usually related to some sort of insult to the central nervous system. So things like strokes, brain injuries, spinal cord injuries. Because of the damage to the central nervous system and because of the injury itself, the brain is now sending a signal to these muscles to remain in a contracted position. So the muscles are contracting. So yes, it is a function of the muscles, but it's because of the injury to the central nervous system that these muscles are staying in a constant state of contraction. So we can stretch them. We may actually gain back some range of motion and some flexibility through our stretching, but typically once that stretching force or stretching is removed, the person goes right back into that sustained posture. So really, until the issue with the central nervous system starts to resolve, the patient will typically stay in that contracted position. The next type is an orthogenic contracture. This is usually the result of some sort of intra-articular pathology. So this can include adhesions, synovial proliferation, joint swelling or effusion, and osteophyte formation. So one of the conditions we see this with a lot is with osteoarthritis. We've mentioned that a little, and we will talk a lot more about it as we get a little bit further into our lecture series here. However, with degenerative changes of any joint, we do start to see adhesions start to form, osteophytes start to form, and when osteophytes or bone spurs start to form within a joint, obviously that gets painful, it gets more difficult to move, and then the soft tissues start to adhere down as well. So these also are a little bit more challenging to deal with because they do have an underlying medical process typically going on as well. The last type is a fibrotic contracture. This is typically irreversible, so it's much harder, again, to get to reverse. This is when there's fibrous changes in the connective tissue surrounding a joint, the periarticular structures, that's most of the soft tissue or anything that's surrounding the joint, tendons, ligaments, muscles. It can be stretched, but again, it's often very difficult to reestablish normal tissue length. So this is usually seen after long periods of immobilization or, again, with some of our injuries to the central nervous system where patients are in these sustained postures almost indefinitely. Over time, those soft tissues can actually start to fibrose, and then it is going to be very difficult to stretch them out of that contracted position. Looking at some terms too, and one thing that we want to talk about, or that I want to talk about as we're talking about stretching, is selective stretching. We just talked a little bit about disorders of the central nervous system and how that can lead to some contractures, but there's also some times where we may actually not want to stretch a patient because it's actually going to improve their function. And pretty much all of the examples I can think of with this do have to do with injuries to the central nervous system. So one example of this would be tenodesis action in the hand of a patient who has a spinal cord injury. I don't know if you've ever seen anything like this before, or if you've ever just seen a patient with a spinal cord injury. Typically we're talking a cervical level spinal cord injury, but their hand is sometimes in this position. If you flip your wrist back real quick, what happens is that your fingers will flex automatically. And so sometimes we actually allow the finger flexors, let me get my hand in the picture there, the finger flexors to shorten over a period of time, because then that can actually make this hand a little bit more functional for our patient with a spinal cord injury if they've lost the ability to grip with their fingers. What they may be able to do is actually hold a pen or a pencil in their hand if they place it there because of that contracted position. You might see them transfer sometimes too with their hands in that position. What can happen is, again, if we go in there and we start to try to stretch out their fingers, you can stretch this away. But then what you may have done too is taken away some of their function. So there are some times that we will allow for adaptive shortening because it does increase the patient's function. Another example would be letting the hip flexors contract a little bit. This could be for a patient with a little bit lower level spinal cord injury, somewhere in the thoracic level. And you guys are going to talk a lot more about this in neuro. But if they do not have the ability through their abdominal muscles and through their back extensors to maintain a nice seated position without any type of trunk support or back support, if we let their hip flexors shorten up a little bit, they won't be able to fall back because their hip flexors are holding them up in that position. So actually letting their hip flexors tighten up a little bit, which they do generally tend to get tight because this person is now probably spending most of their day sitting. Those hip flexors are going to get tight, but that may actually allow them a little bit more function. So sometimes we allow those things to happen. So those would be examples of selective stretching or allowing for adaptive shortening. There is also the possibility of overstretching a patient, which we typically want to avoid. So this would be stretching a person past their normal range of motion, which results in hypermobility. Sometimes this is beneficial for certain sports. Think about like a hockey goalie. How they get their legs in that position is beyond me. Gymnasts, often incredibly flexible and need to be for their sport. However, this can be detrimental at some point because it can lead to some instability at the joints. This is also why it's important for you to know normal ranges of motion for a joint. And basically, once we get a person to that normal end range, that's where we stop, right? We're not going to keep trying to stretch them beyond that point, because then we can lead to some hypermobility and some possible instability issues as well. So some things that we can do to stretch, right? To increase mobility of soft tissues. We can stretch manually, mechanically, passively assisted. We've talked about some of these different methods already, and we'll go into more once we get into lab. We can teach patients how to do self-stretching. Pretty much any stretch that we can do in the clinic, that we can do passively, we can also show a patient a way to do that stretch on their own. We are going to go into some PNF techniques as far as stretching goes. I know that you guys are going to cover these in neuro as well, but there are a few PNF techniques that we can use in the outpatient world as well. Some muscle energy techniques. I am probably going to save them closer to the end of the term and talk about those with you when we talk about joint mobilizations, which is next, joint mobs. We will do a unit on that. I'm sure as many of you know, in Pennsylvania, PTAs are not permitted to do joint mobilizations, but that is not the same in some other states. So we are going to talk about joint mobilizations, and I am going to give you guys some time to lab practice on those as well. We'll talk about some soft tissue mobs and manipulation, and that gets into like soft tissue massage and things like that as well as some neural tissue mobilization or nerve glides. So we'll talk a little bit about those, and we'll start to demonstrate those in lab as well. Indications for stretching include things like limited range of motion, obviously, right, which could be due to adhesions, contractures, scar tissue formation, just any type of inflexibility. We want to generally try to stretch that. Restricted motion that leads to structural deformities. This gets into like postural issues. So again, someone who sits a lot, we've talked about this a lot, but they're going to start to develop tightness in their pecs, tightness in their shoulder internal rotators, and over time it gets harder and harder to then reverse those positions. If there's muscle weakness, this can then lead to shortening of the opposite tissue. So let's use that poor posture example again. When the pecs shorten and that person starts to have the forward shoulders and rounded shoulders and forward head, what's also happening is that weakness is developing in the back and like the rhomboids and your scapular retractors because they're being stretched out over a period of time. So our treatment for that is to stretch out the pecs and the front and strengthen the rhomboids and the retractors and the things in the back. Stretching should also be a part of a total fitness or total conditioning program. And it's a good idea, maybe, to stretch before and after vigorous exercising. You guys have, I know, looked at some studies regarding stretching and exercise. Contraindications to stretching include things like a bony block, just because pushing into a bony block continuously is going to be painful for your patient. So we're not going to do that. If they've had a recent fracture or they have an incomplete union of a fracture, we're not going to try to stretch them until that gets resolved. If they're having sharp, acute pain with movement, this is sometimes difficult for patients to kind of differentiate too, especially those who maybe haven't been as active or haven't done a lot of stretching. We need to try to get them to understand the difference between a stretch, which can sometimes induce a little bit of discomfort, and actual sharp, acute pain. We should not be getting pain with stretching. A little bit of discomfort, a little bit of a muscle stretch, that should go away as soon as the stretch is removed. If someone has a hematoma or tissue trauma, again, we want to let that heal, before we get into stretching. If they're already hypermobile, they don't need stretching. They have plenty of motion. We're good, right? So we don't need to stretch that any further. Or again, if that shortened tissue is going to provide them with some stability or give them some sort of function. So we are going to allow for adaptive shortening in those cases. We're going to talk just a little bit about the stress-strain curve. I believe you guys have talked about this before, so we're just going to touch on it a little bit. But basically, we're looking at some of the properties of soft tissue and muscle specifically. So The property of elasticity is the ability of the muscle or the tissue to return to their pre-stretch length after a stretch is applied. Muscles are elastic, right? You can stretch them, they will go back to their original length. Viscoelasticity is more of a time-dependent property, which again is initially your muscles, your tissue is going to resist stretch, but if it's applied for a long enough period of time, length changes will actually start to occur then. Then that gets us into plasticity. That is the ability to gain and maintain new length. So it is possible, muscle tissue does have the property of plasticity, that you can gain new range of motion. And this gets into the two immobilizing in a shortened versus a lengthened position, which we talked a little bit about in modalities as far as its effect on atrophy. The big thing with that is that if you are going to lengthen one muscle group for immobilization, you're shortening the opposite muscle group. So oftentimes you'll find immobilization occurring in more of a neutral type position so that we're not shortening one versus another muscle. Some neurophysiologic properties. So what I want to talk to you about here is the muscle spindle and the Golgi tendon organ. So the muscle spindle is, muscle spindle is a receptor in the muscles which is going to respond to changes in length and detect tension being placed on the muscle. So when the muscles stretch, type 1A and type 2 afferent sensory nerves are going to cause the muscle that it's being stretched to contract. It's a safety mechanism, basically. It's going to protect that muscle from being overly stretched or stretched too far or too quickly so that no damage can occur. So the muscle spindle's initial reaction to a stretch is to try to resist it, to try to protect that muscle. The Golgi tendon organ is found in the musculotendinous junction. It is a type 1B afferent fiber, so it is also a sensory type fiber. It's going to detect changes in the muscle's tension, and basically it's going to allow the stretch to occur after a period of time. So its main job is to override the muscle spindle. So the muscle spindle, again, is going to try to resist the stretch. The Golgi tendon organ will eventually tell the muscle spindle to calm down and allow the stretch to occur. So again, if that stretch is held for a long enough period of time, and we'll get to timing for stretches in just a minute here, the Golgi tendon organ will alert the central nervous system that there's tension in the muscle and that the muscle should relax to allow the stretch to occur. So again, Golgi tendon organ is going to override the muscle spindle and allow the muscle to elongate. A couple of types of stretches, and again, these are just terms to be familiar with. Tension is force being applied in opposite directions across a tissue, so that would be things like stretching. Compression is force being applied in the same direction, so trying to sort of push the two ends together, and you'll see this when you have a muscle contraction or with weight bearing. Joint approximation would be an example of this, and if you haven't heard that term yet in neuro, you will. And we'll get there, all right? Shear is going to be forces across the grain of a tissue. Here is that stress-strain curve that I promised you we'd talk about. But again, the big thing here is to understand that when we apply more stress or more stretch to a tissue for a period of time, we're just going to hang out in the elastic region, right? Which means we're applying a stretch, the muscle's elongating to some degree, and then we take the stretch off and it goes back to its original shape. What we need to do if we're trying to gain more range of motion is get into that plastic region, right? So we have to go through sort of that yield point, hold the stretch for longer periods of time, do more frequent stretching in order to actually start to gain more range of motion. So you can see both the stress and the strain are increasing in order to get to the plastic region. What we want to avoid is the ultimate stress or the failure point. So again, we can overstretch, that is possible, could potentially get an injury with that, and so that's what we want to try to avoid. Thinking about a hamstring stretch, there's multiple ways to stretch that, but just to use that as an example as we go through some of the different types of stretching. With a quick stretch, again, the muscle spindle is going to fire initially, and the hamstrings are going to resist that stretch. So most of the time when we do stretching with our patients, we're going to do more of a prolonged stretch. Within the literature out there now, a minimum of 15 seconds, 30 seconds seems to be about the going time for most stretches now, because that gives the Golgi tendon organ time to override the muscle spindle, allow the muscle to relax, and allow the muscle to actually be stretched. Some things that we need to think about when we're stretching our patients is alignment and stabilization. Again, if we don't have the patient properly aligned, we may get some compensatory movements, and then we might not be stretching what we're actually intending to stretch. We also have to stabilize the patient to, again, make sure that we are only moving the target tissues and getting the stretch where we want it to be. We need to look at the intensity of stretch. I have a couple videos embedded in here for you guys to watch a little bit later. And the big thing with that is watch your patient's face. Get a feel for how they are tolerating that stretch, or have them rate it for you. They have their patients rate their stretch sometimes on a scale. But again, it should always be tolerable for your patient. The duration of stretch, how long you plan to hold the stretch or want the patient to hold the stretch, the speed of stretching, again, typically we're going for more of a prolonged, slower stretch, the frequency of stretching, and the mode, how are we going to do that? And we'll get into all those things. Intensity, duration, frequency, and mode do have an impact on stretching outcomes. In your book, there's a summary of some of the current literature regarding that. Like I said, we're leaning towards more of a prolonged stretch now, holding for about 30 seconds at a time. Typically, if you're holding those prolonged stretches, we can do less repetitions, but then also frequency is doing the stretches several times throughout the day. So it's typically not, I did one set of stretching, I'm all finished. We typically want our patients to do it periodically throughout the day in order to maintain that muscle length and start to, again, get us into that plastic range. So some different types of stretching. There's static stretching, cyclic or intermittent stretching, ballistic stretching, PNF, manual stretching, mechanical, self, passive, active. So we'll go into some of these different types of stretching. Like I said, there are really, I guess it's 3 types of PNF stretching that I want you to be familiar with. Normally, when I would lecture in the classroom, I would skip over all of this because I would want to just show you these in the lab, because I think they make a lot more sense if you actually see them. I was actually able to find some pretty decent videos of this. This is pretty much exactly what I would show you in lab. So I do want you to please take the time to look at the video for hold relax and look at the video for contract relax. They are very similar in the styles of stretching. However, the major difference between the two is that with a hold relax stretch, you take the patient up to end range, and then they're going to do an isometric contraction into resistance or into you, and you're going to resist that, and then you're going to stretch them into further range. With a contract relax stretch, the patient's going to go up to end range. Now they're going to do an isotonic contraction against you, so you're actually going to move them through a range of motion and then take them back up into a stretch after that. There is a difference between hold relax and contract relax. In the clinic and on most of the videos that I saw, they get these terms mixed up or they use them interchangeably, but according to all PNF guidelines, there is a difference between the two, and it's the isometric versus the isotonic contraction. So watch these 2 videos. I think he does a pretty good job of showing you the difference between those 2 stretches. With either the contract relax or the hold relax stretch, you can also add an agonist contraction. So the procedure would be the same. You would take the person up to end range, have them either do then a hold relax or a contract relax, so do an isometric or an isotonic contraction into some resistance, and then instead of you, the therapist, pushing them up into further range of motion, they're actually going to contract the opposing muscle group, the agonist muscle group, to pull their leg further back. So in the example of a hamstring stretch, take the hamstring up to end range, have them push into your hand, and then instead of you pushing them back, they're actually going to fire their quads, tell them to kick their toes back over their head to pull that leg back into further range of motion. So again, this video does, I think, a pretty good job of showing it. The beginning is a little but if you start at about a minute in, he shows you a very good demonstration of what a hold relax agonist contraction stretch will look like. Sometimes this is also referred to as reciprocal inhibition. So then once we start to gain some more range of motion with our patients, or after we've done some stretching, we want to try to build function into that. Flexibility gains only last about 4 weeks. So if the person then goes back to their old habits, doesn't continue their stretching program, they are typically going to lose whatever range of motion was gained through their stretching program. So again, try to integrate some exercises or functional activities so that their stretching can be maintained over a longer period of time. So when to apply stretching interventions, after the patient has been evaluated and it's determined that they're lacking range of motion or flexibility somewhere, you can then prepare them for stretching, teach them different stretches. If we're going to do manual stretching in the clinic, we'll do that, and then probably teach them again some way that they can incorporate that into home activities, do some self-stretching at home, and then do some functional activities that include that new range of motion as well. We can possibly apply cold. You can try maybe some heat before stretching as well. Again, have the patient do some range of motion exercises once they gain that new range of motion. And then again, develop a balance in the antagonist muscles. So again, now that we have increased range, we also want to make sure that we have the muscular stability to support that range as well. As far as precautions for stretching, make sure that the person warms up sufficiently, that they have proper stabilization. So again, a lot of this is just going to be education on proper form to perform stretching at home. Generally, we tend to avoid ballistic stretching. There is a bigger push now, and we are looking at some ways to do dynamic stretching. But there is technically a difference between dynamic and ballistic stretching. Ballistic stretching is usually shorter, jerkier type movements, but it is a form of active stretching. So make sure your patient, again, is doing them properly. We also do tend to avoid ballistic or dynamic stretching with our older population and tend to go for more of a slow, prolonged stretch with them. Watch out for your intensity. Again, we don't want to overstretch an area. Biomechanics, again, this goes into stabilization and stability. And then again, age-related differences. A younger person is going to stretch a little bit differently than an older person, and we just mentioned that. Things like avoiding some of that ballistic or dynamic stretching with the older population. Some things that we can do in addition to stretching would be things like relaxation training. Again, especially if that person has like that hunched up shoulders, lots of stress. By incorporating some relaxation activities with our range of motion and stretching activities, we can hopefully help to maintain that newly gained range of motion. Heat and cold are both helpful with range of motion, as you saw back in modalities when we did those experiments with heat and cold. Heat, pretty understandable. Cold surprised a couple of people, but yes, cold can actually help with gaining range of motion. I think the big thing there is the cold shuts down your muscle spindles and doesn't allow for that resistance to stretch. Massage can help to augment stretching. Biofeedback, and we talked about that in modalities. And then some joint traction and oscillation. And as we get into the joint mobilizations, and maybe even a little bit with passive range of motion as well in lab, we'll go over what joint oscillation is going to look like. All right, so that is it for that. Don't forget to look at your discussion board questions to follow up with the range of motion and stretching. Thanks, guys.